Hi, everyone. My name's Andrew Huang, and I'm a neurology resident at the University of Rochester. And it is my pleasure to have Dr. Thomas Caprio here. He is the Chief Medical Officer of UR Hospice and the Medical Director of the Home Care Program. And in this short video, we're going to talk a little bit about what hospice is as an introduction.
Sure. Thank you so much for having me. I'm happy to talk about hospice. It's a really important topic that's near and dear to my heart. I've been with the hospice program for over 15 years now and really value this as part of my professional practice.
Absolutely. And to get us started along those lines, could you tell us a little bit about the palliative care philosophy and how it might be somewhat different to hospice care?
You have to think about palliative care is really at the heart of everything that we do. So I look at palliative care as being relief from symptoms and pain treatment. We really try to emphasize meeting a patient's goals rather than affecting, let's say, an underlying disease process. We support quality of life. But the difference is that with palliative care, there's no specific kind of therapy or disease-directed treatment or medications and things that are necessarily excluded from that type of treatment plan. And there's no prognosis in terms of eligibility for palliative care programs. So in other words, for palliative care, it doesn't necessarily mean that it's always end of life care, that person is dying from their underlying illness. It means that we're trying to really focus on quality of life and symptom relief all along that kind of continuum of the disease process. And I really look at palliative care as being a complement to the hospice philosophy. Hospice, on the other hand, the best way to think about it is that hospice is palliative care that's focused exclusively towards the end of life. And so the big deciding factor with hospice is whether or not that person is within the last 6 months or less of their life because of the progression of their underlying disease process and all of their other kind of medical conditions that may contribute to that. But it's exclusively on end of life care. So another way I always talk about it is that all of hospice is palliative care, but not all of palliative care is hospice.
How did the hospice benefit come to be?
So hospice actually has a pretty interesting history. So if you look at hospice overall, it got started back in the late 1950s and early 1960s. And it wasn't in the United States. It was really attributed to the fundamental work that Dame Cicely Saunders did in London with the founding of St. Christopher's Hospice. And she worked closely with clinicians in the United States. And then in 1973, the first US hospice was established in Connecticut. In the mid to late 1970s, national organizations, including the National Hospice Organization, which is now known as the National Hospice and Palliative Care Organization, was formed and provided a lot of kind of the structure, if you will, to the program and thinking about terminal illness. But it wasn't until 1982 in the United States when hospice became a Medicare benefit. So it falls under the federal health insurance that we normally think about as being for individuals age 65 and older in the US to be covered by Medicare. And as part of the Medicare program, the Medicare hospice benefit was carved out as being something that would be provided really at a federal governmental level for all individuals age 65 or older or individuals with chronic illness that may be eligible for Medicare. And that's been used as a model. So in the United States, there is state-run Medicaid programs and there's private insurances which use the same sort of framework as the Medicare hospice benefit. So similar rules in terms of eligibility and resources and the structure to that program. So it's important to keep in mind that for the United States, hospice is very much defined not only as a philosophy of care and a model of care, which is replicated in other areas of the world, but it is also an insurance benefit. Right. So it is regulated like an insurance benefit under the federal statutes as well.
I've heard of it as the insurance benefit, which is so unique to the United States. And if along those lines, could you talk a little bit about where hospice occurs?
Yeah, so that's a good question because oftentimes I hear from patients or families, oh, I don't want to go to a hospice, thinking of it as a building or a nursing home or some place they go to with it. But actually, hospice can occur in many different settings. It's really about the fact that it is a philosophy of care and we provide hospice care across many different sort of care settings, most commonly at home, but in other places, so nursing homes, assisted living, and even sometimes in the hospital. These are usually the most critically ill individuals that really require sophisticated symptom management, maybe intravenous or subcutaneous medications and things to be able to control their symptoms. And we can't really effectively manage that in other kind of care settings. So some hospice care does occur in the hospital as well.
One other question is, what does the hospice team look like?
That's a great question, because one of the real advantages of hospice care is that you do get a team of professionals that are skilled in really supporting patients and families at the end of life. So I think at the core of that team is really the hospice nurses. They have expertise in pain and symptom management. Every patient is assigned a nurse case manager, and there's other nurses who may be making visits. They're available by phone to be on call if there's questions and things that come up. There's also a social worker and a chaplain as part of the hospice team, and that is actually required as part of the hospice benefit in terms of the team members that are working together. And so they help coordinate care and be able to support patients and families and identifying needs in terms of planning and financial planning and taking care of really kind of all of those sort of loose ends that we oftentimes don't think about. The chaplain is really a non-denominational approach, and I really see a huge benefit having the chaplain involved to be able to just support the spiritual needs of the patient and the family. There's also a bereavement counselor that is part of the hospice team. And so that's really one of the advantages, particularly for families, is that after the loss of a loved one, is that bereavement support continues and follows up after that period of time to be able to support those that are grieving. We also have hospice volunteers that work actively with the hospice program. There's always the attending physician. So the patient has a choice of the physician that they want involved in terms of their care. There's also the ability to have the hospice physician, like myself, involved in that care. And we bring the expertise in terms of the pain and symptom management and the sort of the medical care plan oversight. There's home health aides that are part of the hospice program, so they can help with some of the daily hands-on sort of care. It's only a few hours usually in terms of the day that they can provide that support. So a lot is really on the families and the caregivers, particularly in home hospice settings, to be able to provide that hands-on care. And that's really what the advantage of having nurses and others to be able to teach and be able to provide advice in terms of providing the best care for that individual at home. And then I would be remiss without talking about really the center of the hospice team is the patient themselves. So they are really the focus of our attention, and we really focus on, again, the quality of life and the pain and symptom management for that individual.
Especially in our neurology specialty, we commonly have patients, for example, with Parkinson's who are thinking about hospice and palliative care. I was wondering if you could just speak a little bit to your experience with patients with Parkinson's disease.
Yeah, we certainly see a number of patients that have Parkinson's disease and other neurodegenerative conditions. And if you actually look at the history of the hospice program, that back in the 1980s, 1990s, the vast majority of patients took care of had a primary diagnosis of a cancer, right? So hospice oftentimes is associated as a program for patients that are terminally ill due to cancer. But that really has changed. And actually, the vast majority of patients that we care for are what we call non-cancer diagnoses, which include things like Alzheimer's disease and related dementias, Parkinson's disease, stroke, heart and lung disease, liver disease, those sorts of things. So a lot less emphasis towards cancer, although we still care for many patients with cancer and many of these other kind of conditions. I think Parkinson's is a good condition to sort of think about as well, is because we know in the most advanced stages is that these individuals can be quite debilitated, dependent upon care by other individuals. They have changes in terms of their mobility, their ability to get around. They may be losing weight, have difficulty in terms of swallowing. So that makes it difficult both for nutritional intake, but also swallowing medications and things. So we have an opportunity to really be able to streamline medications, maybe use different formulations of medications, pills that can be crushed or liquids and those sorts of things to be able to manage the most bothersome symptoms. And many times in the most advanced stages of the disease is that these are individuals that are really confined to bed most of the time, that really are dependent upon others for care. They may have what we call secondary complications that include things like pneumonia that develops or other infections. They may have areas of skin breakdown, pressure ulcers that form as well with it as they enter into that kind of terminal trajectory of their illness. And it's really kind of those areas that we focus on in terms of their comfort and their quality of life as these changes are occurring. and also managing pain, because particularly with Parkinson's, we realize that rigidity, the changes in terms of their muscle movements, they can develop pain, particularly as their mobility, and the more time in bed is for them, they can have pain that needs to be identified and managed along that trajectory.
Thank you for the insight. I mean, so many of the care partners talk about so many of those symptoms you mentioned, and just so hard to manage at home. I guess as we close, I was curious if you have any takeaway points or advice for families with neurologic illness, or with of patients with neurologic illness.
Yeah, certainly. I think my biggest advice is really to have the conversations early in terms of knowing that, particularly with neurodegenerative diseases like Parkinson's disease, ALS, Huntington's, multiple sclerosis, those sorts of things, as well, is that for many of these patients, at some point, they're going to be on a trajectory where consideration of end of life care is really going to be paramount. And it's always helpful to have those kind of conversations with family members, with clinicians that are involved, to be able to understand that person's wishes, their goals of care, to identify bothersome symptoms early on so that we can be proactive and be able to manage that and be able to smooth the transition. I think that one of the biggest challenges is that we kind of don't want to think about death and dying, and so we sort of relegate that to sort of the last moments when it becomes a crisis. And I don't really feel like that decision making, a lot of the stuff we do in a crisis, is as good as if we could have some earlier discussions and planning and really understand the individual's goals of care.